Welcome to the deep dive. We're going to be taking a deep dive today into the world of subdural hematomas.
Ooh, fascinating.
Yeah. We have this recent article from a leading neurology clinic. These things are more common than you might think.
You're absolutely right.
And there have been some really interesting developments in how we understand and treat them,
Mhm.
especially the chronic type.
It really is a fascinating area.
Yeah.
Yeah, subdural hematomas, or SDH as they're often called, aren't exactly rare.
Yeah.
And the distinction between acute and chronic SDH is key, like you mentioned. It's not just about the timeline.
Right.
It's about fundamentally different processes at play.
Yeah. Let's unpack that a little bit. So we know that acute SDH or aSDH usually follows a major trauma, a bad fall, a car accident, something like that.
Right.
And it seems pretty straightforward. There's an impact, a blood vessel tears, and you get bleeding.
Yes, and the severity of that initial injury is usually pretty apparent. With aSDH, we're often talking about a tear in a bridging vein
Uh-huh.
or sometimes even a cortical artery,
Oh, wow.
which means rapid bleeding because of the higher pressure in those arteries.
Oh, I see.
That's when things can get serious quickly.
High impact, high stakes. But with chronic SDH, it can be a much slower burn, right? The article mentioned that some people don't even recall an injury.
That's right, and that's one of the things that makes cSDH so intriguing.
Yeah.
Instead of a sudden tear, you're dealing with a more gradual process. Think of it as shearing forces along the dural border cell layer.
Hmm.
This can create these fragile, leaky blood vessels that slowly ooze over time, forming the hematoma. It's a subtle process, especially in older adults who might already have some degree of brain atrophy.
Makes sense why diagnosing cSDH can be trickier than aSDH.
Absolutely.
You don't always have that clear aha moment linking it to a specific event.
Hmm.
So let's talk about treatment. The article made it clear that surgery is often the go-to for aSDH,
Yeah,
particularly if there's a large clot or the brain is being pushed out of position.
absolutely. And there are clear guidelines for when surgery is necessary in those acute cases. A clot thicker than 10 millimeters or a midline shift of more than 5 millimeters usually means heading to the OR,
Wow.
regardless of how the patient scores on the Glasgow Coma Scale.
So in those severe cases, it's a pretty clear-cut decision. But the article also mentioned that not every aSDH requires surgery,
Right.
which I found interesting.
Non-operative management is definitely an option in some cases,
Okay.
particularly if the patient is stable and the clot is small.
Right.
This might involve close monitoring in the ICU,
Yeah.
anti-seizure meds, and careful management of things like blood clotting to prevent further complications.
It sounds like there's a lot to consider, even in those acute situations. But things get really interesting when we talk about how cSDH is managed,
Yeah.
especially with this procedure called middle meningeal artery embolization, or MMAe.
It really has.
It sounds like it's been a game changer.
It really has. Remember those leaky vessels we talked about earlier?
Right.
Well, MMAe goes right to the source of those leaks, the middle meningeal artery. By blocking this artery, you cut off the blood supply to the hematoma, essentially starving it.
So it's like turning off the faucet, but instead of water, it's blood.
That's a good analogy.
Yeah.
And the beauty of it is that it's a minimally invasive procedure. But here's the thing. MMAe was first reported back in 2000,
Oh, wow.
yet it took almost 2 decades for it to really catch on.
Now, that is interesting. Why the hesitation?
Yeah.
You'd think a less invasive option would be welcomed with open arms.
You'd think so, wouldn't you? But for a long time, the prevailing belief was that cSDHs were caused by venous bleeding. So the idea of blocking an artery seemed illogical.
Oh.
It took a while for the medical community to shift its thinking and really embrace this new approach.
It's amazing how sometimes, even in medicine, conventional wisdom can hold back progress. But the article highlighted that the evidence for MMAe is now pretty solid.
Exactly.
And that's what ultimately shifted the tide, right?
Multiple studies have shown that MMAe is safe and effective for treating cSDH. We're talking reduced need for surgery, lower recurrence rates, and overall better outcomes for patients. There's even recent level 1A evidence that's the highest level in medicine confirming its efficacy. It's pretty remarkable.
Okay, so MMAe is making waves. But the article also mentioned other approaches to managing cSDH.
Sure.
Can you tell us a little more about those?
While MMAe has become a significant tool, surgical drainage is still a crucial option for some patients,
Okay.
especially those with severe symptoms or large hematomas.
So if the hematoma is causing major problems, surgeons might still need to go in and drain it directly.
Precisely. And even in those cases, there have been advancements in surgical techniques.
Okay.
For example, using drains and body temperature irrigation during surgery can significantly reduce the chances of the hematoma coming back.
That's good to know. It sounds like even in the surgical realm, things are evolving. But I'm curious, with all these options available,
Ah,
how do doctors decide what's best for each patient with cSDH?
yeah.
Because it doesn't sound like a one-size-fits-all situation.
You're right. It's definitely not.
Yeah.
Unlike aSDH, there aren't specific guidelines for managing cSDH.
Hmm.
The decision-making process is very individualized.
Yeah.
Factors like the patient's age, overall health, the size and location of the hematoma, and of course their symptoms all play a role.
So it's a much more nuanced approach.
It really is. And that's why it's so important for patients to have open conversations with their neurosurgeon.
Right.
Together, they can weigh the risks and benefits of each option and come up with a plan that makes sense for their individual needs.
That's reassuring to hear. It sounds like the field is moving in a positive direction, with more options and a greater understanding of how to best manage cSDH.
Absolutely. The future is looking bright for patients with cSDH.
Well, we've covered a lot of ground already.
Yeah.
But before we wrap up this first part of our deep dive, I want to touch on one more thing the article mentioned.
Okay.
The fact that steroids are no longer recommended for treating cSDH.
Right.
I have to admit, that surprised me.
It was a significant shift in thinking. Early on, there was hope that steroids might be beneficial. But more recent trials have shown they can actually lead to worse outcomes and more complications.
Oh, wow.
So, the evidence now clearly points away from using steroids for cSDH.
It's a good reminder that even in medicine, what we think we know can change as new evidence emerges.
Absolutely.
Well, we've covered a lot of ground in this first part of our deep dive into SDH.
Yeah.
We've looked at the differences between the acute and chronic types, explored the groundbreaking MMAe procedure,
Yeah.
and even touched on some of the evolving surgical techniques.
We've only just scratched the surface.
Exactly. But before we get ahead of ourselves,
Yeah.
let's take a moment to absorb all this information. When we come back, we'll delve deeper into the nuances of cSDH treatment, including the different embolic agents used in MMAe and the latest advancements in surgical techniques. Stay tuned. Welcome back to the deep dive. Before the break, we were talking about the different approaches to managing chronic subdural hematomas and how MMA has really revolutionized the field.
It really has.
But as with any medical procedure, there are nuances and ongoing areas of exploration. The article mentions some debate about the best type of embolic agent to use for MMAe.
Right.
Can you shed some light on that for us?
Of course. For a while, the standard choice has been polyvinyl alcohol particles.
Okay.
Or PVA. They're what we call flow-directed, meaning they move with the blood
Right.
and end up lodged in those smaller branches of the artery. It creates a mechanical blockage that stops the blood supply to the hematoma.
So if I'm picturing this correctly, it's like tiny particles creating a dam in the artery.
Yeah.
Sounds pretty straightforward. What's the debate about?
Well, like any tool, PVA has its limitations.
Okay.
Sometimes the particles can clump together before reaching their target.
Huh.
And over time, blood flow might find ways to reroute through new vessels.
Oh.
Also, PVA is radiolucent, which means it doesn't show up on X-rays.
I see.
So doctors can't directly see where those particles have landed during the procedure.
So it's a bit of a shoot and hope situation.
To some extent, yes.
Okay.
But there are other options, like liquid embolic agents.
Okay.
These agents with names like onyx and squid have the advantage of being radiopaque,
Right.
meaning doctors can track their movement in real time.
Oh, wow.
They also tend to create a more permanent blockage.
So less guesswork and a more durable solution.
Yes.
It seems like liquid agents would be the obvious choice then.
There are trade-offs. Liquid agents require a higher level of precision because there's a risk, however small of them, ending up in those tiny arteries that supply the brain or face.
Yeah.
That could lead to complications like stroke or facial paralysis.
Okay, so it's a classic risk-benefit analysis.
Exactly.
You're weighing the potential for a more durable blockage against the need for greater precision during the procedure. What's the current thinking in the medical community on this? Is one type of agent emerging as the preferred choice?
It's still an area of active research, which is exciting. We're always striving to improve techniques and outcomes.
Right.
Preliminary studies suggest both PVA and liquid agents can be safe and effective when used appropriately.
Okay.
Ultimately, the choice often comes down to the specifics of the case and the surgeon's experience and judgment.
It's fascinating to see how these advancements are shaping the field. Now let's shift gears a bit and talk about surgical options for cSDH.
Okay.
The article went into some detail about different techniques and
Yeah.
highlighted some interesting progress in this area as well.
So traditionally, surgery for cSDH involves creating an opening in the skull
Right.
to access and evacuate the hematoma.
Okay.
The size and method for creating that opening can vary: a twist drill, a burr hole, or a mini craniotomy,
Mm.
depending on the patient's condition, the characteristics of the hematoma, and the surgeon's preference.
So different tools for different jobs.
Oh.
But the article mentions some innovations that have improved outcomes after cSDH surgery.
Yes.
What are those?
One major advance is the use of drains, either placed directly where the hematoma was or in a nearby space.
Mm-hmm.
These drains help remove any residual blood or fluid, reducing the chance of recurrence.
It's like making sure you get every last drop when cleaning up a spill.
Exactly.
I can see how that would be important in this context.
And studies have shown that using drains can significantly lower the recurrence rate
Okay.
and even decrease the risk of mortality after surgery.
That's a significant impact. And what about the second innovation?
The second game changer is using body temperature irrigation fluid during surgery.
Mhm.
For years, room temperature fluid was used to wash out the area,
Okay.
but research has shown that using warmer body temperature fluid greatly reduces the chance of the hematoma coming back.
Now that's interesting. Why would the temperature of the fluid matter so much?
It's not entirely clear,
Okay.
but one theory is that colder fluid might cause blood vessels to constrict, making it harder to clear the area completely. Warmer fluid might promote better blood flow and help wash away tiny clots or debris that could contribute to recurrence.
It seems like such a simple change, yet it can make a world of difference for the patient.
Absolutely.
It highlights the importance of constantly questioning and refining even seemingly minor aspects of a procedure.
Even small adjustments can lead to significant improvements in patient care.
Yeah.
That's what makes medical research so exciting.
Right.
The constant pursuit of better ways to treat and manage conditions like cSDH.
It's encouraging to hear about all this progress. So we have these advancements in surgical techniques and this revolutionary MMAe procedure.
Right.
But when it comes to actually deciding on the best treatment path for cSDH, it sounds like there's no magic formula.
That's correct. Every case is unique, and the decision-making process for cSDH is highly individualized.
Okay.
There aren't hard and fast rules like there are for acute SDH.
So how do doctors navigate this complexity?
Yep.
What factors are they considering when recommending a treatment plan for a patient with cSDH?
Well, the patient's symptoms are paramount.
Okay.
If someone is asymptomatic or only mildly affected, watchful waiting might be appropriate, especially for smaller hematomas.
So if it's not causing a problem, sometimes the best course of action is simply to monitor the situation.
Exactly. But if the patient is experiencing significant symptoms,
Right.
like headaches, weakness, or cognitive changes, more active intervention is usually necessary.
And that's where MMAe or surgery would come into play.
Correct. The size and location of the hematoma also matter.
Mm-hmm.
Larger ones, or those pressing on important brain structures, are more likely to require intervention.
It's like real estate, but inside the skull. Location, location, location.
A very apt analogy. And of course, the patient's overall health, age, and any other medical conditions all factor into the decision-making process.
Right.
It's a holistic approach that considers all aspects of the patient's well-being.
It sounds like open communication between doctor and patient is absolutely crucial in these situations.
It's essential. Together, they can weigh the risks and benefits of each treatment option and arrive at a plan that makes sense for the individual.
Right.
No two brains are the same, and the treatment should reflect that.
This has been incredibly insightful.
Oh, good.
We've learned so much about how cSDH is managed, and it's clear that the field is constantly evolving.
It is, and that's what makes it such a fascinating area to work in.
Yeah.
We're always looking for ways to improve patient outcomes and give people the best chance at a full recovery.
Before we move on to our final segment, I want to go back to something you mentioned earlier about MMAe
Sure.
and the fact that it took a while for the medical community to fully embrace it.
Right.
That makes me wonder about the long-term implications of the procedure.
Yeah.
Since it's relatively new, are there still unanswered questions about its lasting effects?
That's a great question, and you've hit on one of the key areas of ongoing research.
Yeah.
We know MMA is effective in the short term,
Right.
but what happens years down the line? That's what we're still learning.
So we've traded the immediate risks of surgery for what? What are the potential long-term downsides of MMAe that researchers are looking into?
Well, one area of focus is the potential impact on cognitive function.
Okay.
Remember, we're blocking a major artery.
Right.
So it's important to understand the long-term effects of that, especially in terms of brain health and cognition.
Makes sense. We need to make sure we're not creating other problems down the road.
Right.
What else are researchers looking at?
Another area of interest is the risk of developing other vascular conditions.
Okay.
Again, we're manipulating blood flow.
Mm-hmm.
So it's crucial to understand if that increases the likelihood of things like stroke or aneurysm later on.
Right.
And of course, we're following patients closely to see if there's any chance of late recurrence of the hematoma, even after a successful MMAe procedure.
So it sounds like, as with any new procedure, there's a need for careful long-term monitoring to really understand the full picture.
Precisely. It's all about gathering data, following patients over time, and constantly refining our understanding of both the benefits and the potential risks of MMAe.
Well, we've talked about how MMAe has already changed the game for cSDH.
Yeah.
But the article hinted at an even bigger shift,
Right.
the possibility of it becoming the standard of care for all cSDHs in the future.
It's a bold idea, and
Yeah.
it's certainly generating a lot of discussion in the field.
Mm,
As the evidence base for MMAe continues to grow,
right?
and as we become more comfortable with the technique and its long-term effects,
Mm.
it's certainly conceivable that it could become the first-line treatment for a vast majority of cSDH cases.
That would be a major paradigm shift in how we approach this condition.
It would?
It seems like only a few years ago, surgery was pretty much the automatic response to cSDH.
It was.
Now we have this less invasive option that might be just as effective, if not more so, in the long run.
It's an exciting time for both patients and practitioners.
Yeah.
But we also need to remember that every individual is different, and there will always be cases where surgery remains the best choice.
Right. The human body is incredibly complex,
It is.
and there's rarely a one-size-fits-all solution in medicine.
Very true.
So even as MMAe gains traction, a personalized approach will always be essential.
Absolutely, and that's why ongoing research, open communication between doctors and patients, and a willingness to adapt as new evidence emerges are all crucial to providing the best possible care for people with cSDH.
It seems like we've come a long way in a relatively short time when it comes to understanding and treating cSDH.
We have.
What are your hopes for the future of this field?
My hope is that we'll continue to see advancements in both MMAe and surgical techniques leading to even better outcomes for patients. I'm particularly interested in seeing how the long-term data on MMAe unfolds and whether it truly lives up to its promise as a potential cure for cSDH.
It's inspiring to see how innovation and dedication are driving progress in this field. We've covered a lot of ground in this deep dive, from the basic science of SDH to the cutting-edge treatments that are changing lives. As we wrap things up, what's the key takeaway you want to leave our listener with?
The main message is that the landscape of cSDH treatment is constantly evolving. MMAe has emerged as a groundbreaking option, and we're continuing to refine surgical techniques. There's reason to be optimistic about the future for patients with cSDH.
And I would add that staying informed and engaged in your own healthcare is paramount.
Absolutely.
Don't be afraid to ask questions, research your options, and advocate for the best possible care.
I couldn't agree more. Knowledge is power, and when it comes to your health, it can make all the difference.
Well said. And on that note, I want to thank you and our listener for joining us on this deep dive into the world of subdural hematomas.
It's been a pleasure.
We hope you found it informative, thought-provoking, and perhaps even a little bit inspiring. Until next time, stay curious and keep learning.